Hi Venus, I'm back here to discuss one more important topic related to your community dentistry. As already discussed in the previous video about different types of study, now I'm going to discuss two important studies which are most commonly asked for us. That is cohort and case control. Okay, so it's very simple that most of you have did this at your best, that the difference between cohort and a case control study is a star question for your final year university exams. And you simply know that one goes in opposite direction. Like cohort is quite opposite to the case control in most of the situations and most of the conditions. So it's better we learn one type of study and most of the things are opposite to other study. So coming to the first aspect, that is cohort study. Cohort study, and the second aspect is the case control study. So cohort study is a forward study. Forward study means simply, I'm going to give a simple example that, okay, a high carbohydrate sticky food, on taking a high carbohydrate for a sticky food for a longer duration of time, for example, a 5 years or a 10 years, which may lead to dental caries. This is hypothesis, which may lead to dental caries. Right, this is a hypothesis, means this study is moving forward. So this is an example of a cohort study, means you are watching a person or a group of people who are taking high carbohydrate sticky diet every day. On observation of 5 to 10 years, there is a dental caries occurrence. Similarly, you can do this in reverse direction. Okay, you have selected a people who has dental caries, and you got the history from them about their dietary habits. Okay, means you are going in reverse direction. That study is called as case control study. Cohort study is a forward study. It is also called as prospective study. Okay, whereas case control study is called as a backward study. Okay, a retroprospective study means study which is going backwards. For example, in most of your questions, they will give you a study has started. Okay, a study has started, okay, in the year 2020. And we are studying for the upcoming 10 to 15 years. For example, 10 years. The upcoming 10 years, that is 2030. Means the date simply shows that the study is moving in forward direction. This is a cohort study. Similarly, they are going to give a cases were taken, disease cases were taken, and their history was taken 10 years back from a hospital or from any other source. 10 years back means if the dates are going in a backward direction, then it is called as a case control study. There is one exception, something called as nested case control study. That is called as nested case control study. Means nested case control study is nothing but a combination of cohort study as well as case control study. Okay, simply nested case control study is a combination, means is a combination of both. Means now you are in 2020. Okay, for example, you are talking about regenerative endodontics cases. So already in a particular department in the last 5 years, from 2015 to 2020, there were lots of 100 regenerative cases were done. And similarly, you are planning to do 100 more cases from 2020 to 2025. So this study is going in forward direction. Okay, but you are collecting data in backward direction also. So it's a combination of forward direction and a backward direction. That is called as nested case control study. Okay, that is called as nested case control study. It's the simple, you can add a word to nested case control study as a small case control study which is nested in a cohort study. Is a small case control study which is nested. That is the reason why it is called like that, which is nested in a cohort study. So they can simply ask, nested case control study is which type of study? Is a cohort study because it's moving forward. It's mainly a cohort study, but you are collecting data in retroprospective direction also. So it is a case control study. Nested case control study is more often a cohort study. The major aspect is cohort study as it is moving forward, but you are collecting some data previously also. So it is a part of case control also. Mostly it is a cohort study, but a part of case control. So don't get confused. Nested case control means most of us feel that it is a case control study. But no, it's not a case control study. It is majorly a cohort study with some amount of case control study. I hope you're very clear. So they can give you something like this, some example like this. So you have to go for a better option like nested case control study, because a study which is moving both forward as well as backward is a nested case control study. I hope you are very clear. That nested case control study is most commonly used for diseases which are new, or diseases which are rare, or techniques which are new. For example, now in this particular example, I'm talking regenerative endodontics, which is a new technique, or a condition in which the diagnosis is impossible or very expensive. For example, if you want to go for diagnosis of pulp vitality in this case, it's very difficult to analyze the pulp vitality in this case because we have very less equipment for that. Okay, so when to be done for this study is the disease should be rare or new, or the technique should be rare or new, the diagnosis is impossible or expensive. In such conditions you can do nested case control study. Hope you are very clear with this, right? So I'll be talking more about cohort study now, and you can learn the quite opposite is the case control study. So cohort study, as already discussed, is a forward moving study, is a prospective study. Okay, so what prospective? In 2020, okay, you have taken 100 cases, and all these 100 cases are being exposed to the smoking, predicting that by 2025 or by 2030 you are expecting periodontitis. This is your hypothesis, that smoking is a cause of occurrence of periodontitis, and your study is moving forward direction. This is your cohort study, right? I hope you're very clear with the cohort study. The main disadvantage is because as it is taking 5 years time or 10 years time, as it is moving forward, the main disadvantage of this cohort study is time consuming. It is consuming most of your time. Okay, and most of the things, as already mentioned, your smoking, the smoking here, as we have taken as a etiology or a risk factor, you have some keywords which are used in this particular study. Smoking can be called as a cause. It can be called as a cause, or smoking can be called as an exposure, or the smoking in this particular can be called as a risk factor. Okay, so if it is a risk factor based thing, it is called as, the outcome is called as effective, means the periodontitis is called as an effective. If it is exposure based things, it is called as outcome, periodontitis as outcome. If it is a risk based thing, the periodontitis is called as disease. So the case control, the cohort study can also be called as cause and effective study, can be called as exposure and outcome study, can be called as risk factor and disease study. It can be called as any of these. These are the other terms that are used for the cohort study. And as already mentioned, like what you are going to do in cohort study in this particular case, in 2020, you have taken 100 cases and they started smoking, and you are going to identify the periodontitis. And out of which in 2021, you have identified 2 cases developing periodontitis. In 2022, there were 4 cases which has developed. In 2023, there were 10 cases. In 2024, 0 cases. In 2000, I'm just giving an example, 25, there may be 50 cases developing periodontitis. So every year you are checking the number of cases, the number of new cases. So the number of new cases are, what are the number of new cases in a particular duration of time, called as incidence. So this study is also called as incidence study. Okay, it is called as cost effective study. It is called as exposure outcome study. It is called as risk factor disease based study. It is called as incidence study, as you are getting the incidence and everything. Okay, so what is the aspect? Like you're just taking you're just taking the normal person who is being exposed to the caries, who is being exposed to the smoking and periodontitis. Okay, similarly, there may be other factors also leading to periodontitis. Smoking is one factor. Okay, there may be other factors also leading to periodontitis. So how you have to take this particular case in 2020? Okay, So there were few people who were exposure, and you have to take non-exposure group also. So you have to take 100 exposure group to smoking, 100 non-exposure group. Okay, so by 2030, 80 people have developed periodontitis who are smoking, and the second category, there were only 10 people who are developing periodontitis. They are not smoking, but they have periodontitis that can be due to any other reason. So this is an example that we are taking. So you have to take two groups for comparison. One is the exposure group and second one is the non-exposure group. The exposure group here is the smoking. The non-exposure group can be any other factors. So by taking this data, if particularly this data is given, that is most oftenly related to cohort study. So with this data, you have to get the strength of association. How to get the strength of association is, there are three important parameters for getting the strength of association in cohort study. They are, one is the relative risk, the second one is the attributable risk, the third one is the population attributable risk. Okay, there are three factors. One is relative risk, second one is attributable risk, third one is population attributed risk. So these are the three things which helps in knowing the strength of association, between the smoking and everything. Okay, mostly the strength of association is obtained by relative risk. I hope you are very clear until this point. Okay, so now you have to compare the other aspects. Okay, what we are going to compare? First, we are going to talk about the relative risk. Okay, so what is relative risk? Simply, okay, relative risk is equal to, you have to remember these formulas. Incidence among the exposure by incidence among the non-exposure is a relative risk formula. So if you take the relative risk formula for this particular case, incidence among the exposure is 80 persons getting periodontitis out of 100. So incidence among the exposure is 80 by 100. And incidence among the non-exposure is 10 by 100. So it is 8%. So not percentage, it is 8. Okay, the relative risk value is 8. So what this 8 means the relative risk, okay, of smoking is 8 times more than a non-exposure thing to cause periodontitis. Means smokers causes 8 times more prone, or relative risk is 8 times more when compared with non-smokers. Okay, so what relative risk value gives us? Relative risk value, if it is greater than 1, it gives a positive association. Relative risk value 0, 1 gives, equal to 1 gives, there is no association. Means you can conclude that smoking is not a relative risk factor for occurrence of periodontitis. If relative risk value is less than 1, then it is called as a negative association. Negative means it is a preventive measure. Means smoking is a preventive measure for occurrence of periodontitis. Okay, so now the value is 8, means more than 1. Means smoking has an association with occurrence of periodontitis. How many times? 8 times occurrence. That is what the relative risk is going to give you. So we are done with the first one, that is relative risk is over. So we are going to the second one. What is second one? Attributable risk, AR, right? So we are done with relative risk. Now we are going to talk about attributable risk. Okay, so what is okay, so next one is attributable risk. So you need to make a note about this formula. Attributable risk is equal to incidence among exposure minus incidence among non-exposure by incidence among the exposure into 100. Make a note, don't forget this 100 because this is a percentage. Okay, so what is incidence among exposure? Is 80 by 100. Incidence among non-exposure is 10 by 100 by incidence among the exposure is 80 by 100. If you calculate this, you will get a value of 88%. So what does this attributable risk gives an idea? That smoking is an etiology. The etiology of smoking is 88%. Means the occurrence of periodontitis in the smoking people. Okay, smoking people, or the association of smoking as an etiology is going to be 88% is the inference that is given by the attributable risk. So the last one is population attributable risk. So the formula for population attributable risk is incidence among the total population minus incidence among the non-exposure by incidence among the total population. So the total into 100. Okay, the total population is 200 here. So incidence among the total population is how many people are getting periodontitis is 90. By how many people are there? 200. Right? Minus non-exposure is 10 by 100 by 90 by 200. So this is going to be somewhere around 77 or 78% if you calculate it. Okay, so this is going to give an idea. If you prevent smoking, there will be drop of 77% of the cases. Okay, so it's a preventive measurement which can be taken to entire population, that if you prevent this particular factor, the occurrence of smoking or the periodontitis will be decreased by 77%. So these are the three important factors. The number one is relative risk, number two is AR, number three is PAR. So these are the three parameters which we are going to get with the help of a cohort study. Okay, I hope you are very clear. So other important things, the other names are forward-looking study, prospective study, study which moves from cause to effect, study which moves from risk factor to disease, study which moves from exposure to outcome. This is also called as incidence-based study. So all these things which we have discussed. And they can ask you one more question. The minimum number of cohorts that are required in cohort study is the minimum 2, because you need to compare like one exposure group, one non-exposure group. The minimum number of cohorts that are required is 2. Okay, so you can ask me that how the relative risk or attributable risk or PR, where they are used or how they are used for a normal thing. Okay, so relative risk is most commonly used by the clinician. By the clinician, normal physician will take this relative risk into consideration and will explain the patient that if you do smoking, the risk of smoking for periodontitis will be 8 times. So this is how a clinician will use relative risk most oftenly. Next, attributable risk is most commonly used by epidemiologist. Okay, attributable risk will be used by this particular individual when he collects a data. Whereas the PAR is something related to entire population, which is used by public health program manager. This person is going to use that, okay, this factor is how much influencing the occurrence of periodontitis in a smokers or in a smoking population. Okay, I hope you were clear with the concepts what we have learned related to this. So now we are going to solve few important MCQs. Okay, the study of smoking for 10 years and occurrence of periodontitis is similar example what we have discussed. So you are planning to study the effect of smoking to occur the periodontitis, means it is simply going in a forward direction. You are not collecting any information. The answer is cohort study. How it can be a case control study is, you have selected the smokers. Okay, 100 smokers were selected, and their case history about the smoking in the last 5 years was collected. Means then you are going in a reverse direction, then it's going to be a case control study. The second one, calculate the relative risk. In which the incidence of the disease among the exposure is 20 and non-exposure is 4. Okay, so exposure incidence is given as 20. Incidence among the non-exposure is given as 4. So they are asking to calculate the relative risk. We have learned the formula of relative risk, that relative risk is a ratio between the incidence among the exposure by incidence among the non-exposure. So incidence among the exposure is 20, non-exposure is 4. So the relative risk is 5. Okay, the relative risk value is 5. Hope you are clear with this. The next one, attributable risk is measured by. So we have learned that there were three associations that we are measuring. One is relative risk, second one is attributable risk, third one is population attributable risk. So all these are measured in cohort study. So attributable risk is measured in cohort study. Next, attributable risk gives a brief idea about, we have already learned, relative risk is going to give how many times that this particular cause is a risk factor for causing a disease. Attributable risk will talk about the etiology, that for particular etiology which is causing this disease in a particular group of individuals, this percentage. So we have already learned about this. So this talks more about the etiology factor or a factor in the disease, right? So thank you for now. Signing off, Dr. Srikanth from team MDS CONQUER. So we have done different studies and we have almost completed the case control study and cohort study. Okay, so I hope you can manage when they give a description of a particular study, you can clearly identify that which study this is, and of course now you can calculate the relative risk, attributable risk, and the population attributable risk, and you have learned some important advantages and the disadvantages. And of course please do try to finish that the difference between the cohort study and case control study, which is there either in your Shobhan Pater or Park or the Vivek Jain social medicine MCQ book. Any of these they were beautifully given. So all the differences has to be you need to make a note, because most of your questions will move around case control study and cohort study for sure.